Good afternoon, everyone, and welcome to this installment of our COVID-19 pandemic preparedness webinar update for April 17th. My name is Aaron Lebo. I'm the Vice President of Communications and Public Affairs. Pleased to be moderating today's discussion. And I have with me a number of guests who are contributing to topics that we have put into today's webinar based on feedback we are getting and questions we are getting from the staff COVID-19 email line, and as well to address topical issues that are occurring this week. As always, to try and keep you up to speed on the latest that's happening in our effort to be prepared for COVID-19 and work through the pandemic together. I'm joined today by Rob McIsaac, our President and Chief Executive Officer, by Dr. Dominic Mertz, HHS's Medical Director of Infection Prevention and Control, as well as Dr. Wes Stephen, our EVP Clinical Operations and Chief Operating Officer, as well as Sandra Andrzejczyk, a clinical ethicist in the Office of Interprofessional Practice, and Michelle Leroux, our Vice President of Human Resources. Thank you all for being a part of this today. Rob, I'll go to you first as we head into the Friday of another week addressing this pandemic. What's your view? What do you see that's happening this week that we need to know
about? Okay, well, thanks, Aaron, and thanks again to everyone for listening today, and also for your ongoing dedication and determination in the face of this virus. I continue to be so impressed by what has been accomplished by the HHS team in a relatively short period of time, and also very grateful for the impressive work that's being done. We haven't seen the surge of COVID patients we were worried about. I think that's probably apparent to everybody, but it's important to know that we continue to plan for the possibility that we'll see spikes in the number of patients we're seeing in our hospitals. Given that we appear to be on a lower curve, seeing less patients, we're starting to consider how we might begin to ramp up some services that have been scaled down to make room for COVID care. COVID is not the only thing that is making people unwell in our community, so we have to have regard to the broad spectrum of patients that need us in our services. Dr. Stephen will speak more to our capacity planning in just a moment. I'm sure many of you have noticed that the hardest hit segment of our community thus far has been people living in congregate settings, places like long-term care homes and retirement homes. The virus has placed a huge strain on those sectors. We're working with our community partners to develop plans to see how we can be part of the solution to protecting these people who are so vulnerable to the virus. We already have some supports in place, including a model that gives healthcare workers in long-term care facilities virtual access to emergency room staff and to other care pathways for residents in their facilities. As this work comes to fruition, we'll share details in the coming days about our planning and how HHS is going to play a role in developing a solution for these people. Although we're not experiencing the surge we projected, and that's a wonderful thing, we continue to care for patients with COVID in our hospitals. And some of those patients have very acute care needs. Our ethics team has done incredible work to support frontline clinicians to have difficult discussions with families and patients to determine and communicate their goals for care. Sandy Andrzejczyk, clinical ethicist at HHS, will provide an overview of this work today, which is important work on any day, but especially important in light of COVID. Maybe just to finish off, although it seems we may have evaded the worst of COVID locally, we're still very much in response mode, and we're relying on everyone at HHS and everybody in our community to keep doing what's required to minimize the impacts of this virus. As always, please continue to follow the direction of government officials in terms of physical distancing, and also please continue the great work you've been doing to keep yourselves and each other safe inside our hospitals. It's very nice to hear the discussion beginning to turn to how we will come out of this very strange place we've all been inhabiting in the last couple of months. And I know that this exit will not be a fast one. We will need to do this gradually and carefully. Still, the discussion is a wonderful glimmer of light in what's been a rather dark journey. So thanks all for listening today. And once again, thanks for all the work that you're doing. Back to you, Aaron.
Thanks a lot, Rob. Dr. Dominic Mertz, we're coming to you next for a bit of an update around the numbers we're seeing. I mean, as we all read media these days, we hear an ongoing discussion about whether or not we've reached the peak or the apex of the challenge for us in Canada and Ontario locally. What do we need to know about how things are shaping up here in Hamilton? Like, how do we put what's happening in our region in the context of this discussion? Can you give us some insight?
Yeah, thanks, Aaron. So I start off as usual with just the counts and then go into how this looks like in terms of the actual curves. So as per April 17th, we have 306 confirmed positive cases in Hamilton. The proportions remain the same. 13% of the cases were hospitalized. We have a total of 11 deaths within the Hamilton Public Health Unit to date. Almost 20% now of the patients that were tested positive are long-term care facility residents, and that goes back to what Rob said previously, that it's this sector that it is most significantly hit by this pandemic. And roughly 40% of the cases have been resolved. Now, let's switch to the Ontario picture on the next slide. Okay, here you see the epi curve for the entire province. And as I always say, don't look at the last bar there. This is going to change. Have we reached the peak? It sort of looked like we are hovering at this peak level. There's no increase, but there's also no decrease. So again, it's a flat curve, but it seems to be, if this is the peak, that there's a long peak and it's not decreasing yet. When we look at Hamilton on the next slide, I'm showing you a slightly different picture this time. So this is the actual number of new cases per day. So every circle here represents the number of daily cases. And then you see a line which shows you the prediction in a model by a group from Toronto. And you see, based on this model, we should be at almost no new cases by May. Or May 1st. And you also see that those circles are very close to that modeled line, but the last couple of days, it's above it. And in particular, yesterday, it was significantly above it with 30 cases on one day. Now, many of those cases are asymptomatic individuals who were captured during the workups of outbreaks in long-term care facility and retirement homes. So not really representative of symptomatic COVID-19 patients that would have made or influenced the rest of the curve you see here. So it doesn't necessarily mean that we are now going into a peak mode here. But again, it shows us we are not out of the woods yet. It's very similar to what you saw on the epi curve for Ontario. It looks like we are in a prolonged peak mode, not increasing significantly, but not decreasing significantly either. And whether we will be down to only the occasional case by May needs to be shown. That's just the model. And as we always know, models, well, tend to be wrong, but it's the best we have. Thank you. Back to you, Aaron.
Thanks very much, Dr. Mertz. Dr. West Stephen, over to you next. I mean, given what we're talking about in terms of the numbers and maybe even a prolonged, steady, low peak, how does that impact our capacity planning and what we're thinking about in that regards?
Thanks, Aaron. We are in a continually evolving situation where our surge and capacity planning has to be extremely adaptable and nimble. We continue to work with our local, regional, provincial, and federal partners to ensure we have the appropriate capacity to meet the projected need. Along with these partners, we continue to monitor the landscape and prepare for the future. At this time, HHS is well equipped to meet the needs of our community and region, thanks to an extraordinary efforts of everybody at Hamilton Health Sciences. Our current capacity, which includes a reduced level of scheduled care, would suggest that we have exceeded the provincial target given to us for the beginning and at the end of April. We currently have 350 beds freed up for patients with COVID-19. At the present, we believe we have also more than enough ventilators. We actually have 155 at Hamilton Health Sciences to meet the needs of the community for COVID patients. If our need should ever exceed this capacity, we do have access to the provincial stockpile, which is housed at the McMaster site, ventilator loaners and anesthetic machines. And we also continuously are planning to add more acute care beds and increase our critical care capacity if it is required.
So given that, Wes, how much capacity do we currently have and how much do we need to maintain in the weeks that are ahead?
So we know that the intensity of care and the length of stay in the ICU for COVID patients can be longer than normal. And this has to be factored in when we start to look at reintroducing care that has currently been on pause, particularly those cases that might require a planned or an unexpected stay in the intensive care unit. We also must pay attention to the risk of easing up on our current measures, such as physical distancing, as advocated by public health. Our current state is very much dependent on flattening the curve, and not only on our hospital preparedness, but how the individuals in our community are responding. Locally and beyond, we will still see a steady stream of some COVID positive patients. We hope to learn more as testing increases, and the current models and projections will need to be updated. As always, we will ensure ongoing alignment with provincial directives and regional planning efforts.
And with this situation evolving the way it is, I mean, just last week we were talking about securing alternate hospital space in a hotel or convention facilities locally. Do we still need that off-site space for non-COVID care to free up space inside our facilities?
We have created a great deal of capacity within our walls, thanks to everybody and the work that's been done by so many. At this time, because we feel our hospitals are well equipped to meet the need, there is not an immediate need to utilize spaces outside of the hospitals. In recent weeks, we have been in discussions with Rancor Group about the use of their hotel space at 116 King Street West as an alternative health space for non-COVID patients. Based on provincial direction and our local context, we are not pursuing this option at this time, but it remains on the table in the event that we need to create an off-site capacity to accommodate a surge of COVID cases. Rancor has been an outstanding partner, and we will continue to work alongside all our external local partners to address all our local planning needs. Many people from across Hamilton Health Sciences and St. Joseph's Healthcare have been involved in detailed planning around 116 King. Their incredible efforts deserve recognition. They have made much possible in a matter of mere weeks. We'll continue this planning, so we will be ready if and when we need to utilize this space. This is another demonstration how well Hamilton partners continue to work together to care for our community and our patients.
Thanks a lot for that update, Wes. Sandra Enderchuk, I'd like to come to you next. I know as we talk about planning on an institutional and an organizational level, people have been planning at an individual level too as COVID enters our community, and that includes advanced care planning and establishing goals of care. I know there's been a lot of work undertaken at HHS in this area that you and others have been leading. Can you talk about this? What are goals of care? And what is the work that has been done at HHS in light of COVID?
Yeah, thanks, Aaron. Really, really important subject for patients and for clinicians and for leaders alike at HHS. As we work in the midst of COVID-19 and the pandemic, it seems as though it isn't the right time to talk to patients about what their hopes and values are, but in fact, it is the exact right time. It really is important that we understand our patients' wishes and their values. And even if we're only able to spend a very short period of time having these conversations, taking the time to do this helps patients feel heard. It helps minimize their feelings of isolation, especially in a time in which we have very stringent visitor rules that are being applied. It also helps contribute to the patient's understanding of some of the recommendations that might be put forth by their medical team. So there's many, many benefits for the patient in engaging in conversations about the things that matter most to them. And I do find that when we begin to have conversations around health preferences, it also helps patients to identify who their substitute decision maker would be. And sometimes we get confused a bit between what a next of kin versus a substitute decision maker is. And this is an opportunity to delve a bit deeper into that with the patient, which often becomes very important, particularly around end-of-life decision-making, as we know that many of our patients lose their ability to speak for themselves. And so the idea of identifying somebody who would speak on their behalf is really important. The other thing that we tend to do in healthcare is make an assumption that everyone would like to have full resuscitation and full critical care services. And in fact, many patients may not choose that route for their own journey towards end of life. And so these conversations help bring that out as well, the things that are important around their care towards end of life. And so when we talk about serious illness, it typically is patients that would be identified as that last segment, portion of their life. So next slide. So when we think about engaging in these conversations, we think about how as a clinician can I prepare for this, and what are the benefits to clinicians. So we've done a lot of work in the organization around scripting and looking at various tools that can help lead a conversation that really brings forth the perspective of the patient, but also the recommendations and opinions of the health professionals. So it really does allow for good communication within a short period of time. And it's not that we want to rush these conversations, but we also recognize that the workload can become very overwhelming for clinicians, and to sit and be with a patient for a long period of time might not be possible. So if you're really prepared, you can get a lot accomplished in a short period of time and still build rapport with patients and allow patients to feel heard, which is really important. We also make sure that by scripting, we don't miss important points. There's many important points that we need to accomplish in a conversation that really elicits patients' values and wishes. And so we don't want to miss any important things that are going to help us make some good recommendations to the patient based on what they're telling us their wishes are. It also provides us an opportunity to sit and talk about how things could change over time. We always want to talk within the present moment, but often recognizing that anything can happen at any given moment. And so we want to talk about that with our patients as well. It also, by scripting and by thinking about how we're going to engage in that conversation, it gives clinicians the opportunity to address some of the strong emotions that might come up for patients during this time. So that's really important to be prepared for that. And then also, when we are prepared ahead of time, it helps us to make some really good decisions in the moment. When the decisions that the patients are making and the care plan that we've helped them create for themselves can then be applied in a situation in which it's necessary. So you can go to the next slide. And so what we've done at HHS is we've taken a number of different sources throughout our health community and our bioethics community and melded them into what we believe is some really good tools, both patient-facing and clinician-facing. And I think when we do this, we know that these conversations can be difficult, but it does prepare the patient so that they can fully engage. And so by giving a patient an information sheet or an education tool ahead of time, 1 or 2 days ahead of time, it gives them an opportunity to really understand what the physician or the health professional might be asking them during that conversation, so that they can think about these things beforehand, and then the conversation can be a two-sided conversation versus clinicians just sitting down, giving information, and then making proposed recommendations and then walking away. And so really what we often say to people is that if you're engaging in a serious illness conversation about goals of care, it should be a 50-50 conversation, meaning the patient should be speaking 50% of the time. And sometimes that doesn't happen. And if you can go to the next slide. So when you think about conversations with patients, we often think about consent conversations, and that's often about giving information about the proposed intervention, and you're giving the risks and benefits, you're giving alternatives, you're giving information about what would happen if the intervention was not provided. And so when we think about our typical consent conversation, there's a lot of information sharing from the healthcare team, and very little except for the understanding from the patient themselves. And so the serious illness conversation looks much different than that. It really is about following a flow that helps set up the meeting. It helps elicit the patient's values and wishes. It helps understand the person's their understanding of their prognosis, and also exploring some important topics that are vital for them, such as their fears, their worries, what gives them strength, what gives them support, and their family members, what they would be willing to trade off for more time, and also what are their critical abilities that they just couldn't see themselves living without. And so that becomes a very fruitful conversation that really becomes about the patient. Hearing all of that, it helps the clinician make some good recommendations for the patient. So some of the really important elements of this conversation is that, first of all, you familiarize yourself with the guide. This is really important. And the clinicians will say to me that they don't really like to use scripting, and they don't like to have a piece of paper in front of them when they're talking to their patient or the substitute decision maker. And I always remind people that it's okay to have notes in front of us to glance down at and look at, and even to tell the patient, you know, I have a tool here. I want to make sure I capture all the things that are really important to you. And so I am going to utilize this tool to make sure that I don't miss anything. And so that's okay. It's okay to time. Some people like to do that, and other people like to just read right off the script. Whatever feels comfortable for you is the most important thing. It's important also to stick to the language, because the language is really important in regards to open-ended questions, and also asking the right questions so that you elicit the right information from the patient. And by right, I mean what's right for them. And it really is in the way we ask the question. It's also working with the substitute decision maker, who this may not be possible in the pandemic situation, in that we're asking visitors and families to not come into hospital. So it's really important that we become creative in either using video, or making sure that the substitute decision maker is on the phone so that they're hearing the same information. Some of the other things to think about is when we're working with interpreters, it's often important to discuss some of the questions ahead of time and review that with the interpreter, just in case there might be potential challenges in how that's translated. The other thing I think is really important is the use of silence and acknowledging emotion, because some of these conversations can be quite difficult when we're talking about things that are fearful, the worries, that stirs up a lot of emotion for people. And so we need to be able to use silence. And oftentimes that can be a really hard tool to use because many people don't like silence. We also have to remember that we should never struggle alone. We should be able to debrief with our colleagues and to also consider the self-care that we need. In our organization, we've had several members of our teams who have been trained in value-based goals of care conversation using our serious illness conversation guide. And so we do have a pool of people that are willing to support other clinicians in preparing for these conversations. So I think people should know that and not hesitate to reach out as needed. You can go to the next slide, Erin. So all of our materials that we've created specific for COVID can be found on the Ethics Hub site under Goals of Care. And some of the tools that we've created are the patient information sheets, which help prepare the patient for the conversation. We also have material that we can give to a substitute decision maker so that they're prepared as well. We have scripted guided conversations for patients that are diagnosed with COVID, but also patients that are not. We have little tips on conversation starters and also an FAQ sheet that will give you some answers to some of the frequently asked questions about COVID-19. We've also been able to access videos from our colleagues at Ariana Labs as well as Providence Health that have developed serious illness goals of care videos, both for general conversation, but also in the face of COVID-19. And then we have a number of references and other resources that are available to staff. So I'll just show one last slide, and that's the flow diagram. And this is, the viewers probably can't see the detail in this slide, but basically what this slide is trying to represent is that there is a systematic approach to having conversations and first identifying the patient, then identifying what material would be best to give them ahead of time to prepare them, the script that you might want to utilize in having the conversation because we've got a couple to choose from, and then also important to note that we don't always encourage that these conversations should end in the development of a code status, but definitely if that's an outcome that's been concluded at the end of a conversation, it's really important to document that on our physician order scope of treatment post form, which would then be put into the green sleeve at the front of the chart, just in case there was an incident in which the person deteriorated and required some form of support during that time. And that way all the team knows what the patient's wishes are, which ultimately is what we're striving for. So that's sort of wraps it up in a nutshell, the work that's been done, Erin. So I hope that's helpful for the viewers to understand a little bit of the resources that are there for them and for their patients.
Thanks very much, Sandy. Really appreciate you giving that update on all of this work. Well done, and thank you for that. So moving forward, next I'd like to ask you, Michelle Leroux, a question that keeps coming up on our staff email line. You know, as we've talked about earlier in this presentation, we're seeing some changes in the prevalence and the numbers, but we're still taking strong measures to prevent the spread of COVID, and that's really important. But as it relates to the self-screening, I mean, is it effective? Do we need to keep doing that? What would you say to those questions?
Thanks, Aaron. Yes, we need to continue to make our health and safety and that of our colleagues and patients a priority. We need to continue to self-screen before we come to work. This tool was designed to help empower us at HHS to do that. And it's important that we all continue to make that a priority. It helps us stay current on the ministry-approved guidelines for screening, and that's why we have this great automated tool.
And what are the expectations of staff and physicians in terms of self-screening?
You know what, it's important where possible that you complete this at home, as many of you do before you get to work, so that when you get to the screeners, you're just able to show either your screen print or your device at the door, and you're ready to move forward quickly. You know, it's important that you remember that these screeners are your colleagues. These are team members who are there to help you move forward quickly to get to work, to make sure the safety of our staff and our community are a priority. You know, as we come together for our patients during COVID, I just encourage everybody to remember, as you're trying, as we all are, to get to work quickly, to do our jobs, to care for our patients, a reminder to treat each other with respect. We're all doing the best we can, to take time to show gratitude and recognize each other. Whether it be your colleagues or the screeners at the door, we're all here doing the best we can for our patients.
Absolutely. We should all be grateful when we're able, and thanking one another throughout this process. I'd like to thank all of you for being a part of this webinar today and helping to continue to bring information to everyone at Hamilton Health Sciences as we go through our pandemic planning and preparedness. We have a lot still to do, and we'll continue to hold these webinars as much as is needed to bring information to everyone in the organization. As always, if you have questions, you can send them to the staff COVID-19 at hhsc.ca email address. We'll get a response back to you as quickly as possible. And we'll also be looking at the themes and specific questions that come up at that email line to formulate future webinars. These broadcasts are based on that, as well as what is important and topical in any given week. Please continue to go to the Hub for updates, and if you have not already done so, download the Hub app so you can have those updates pushed to your mobile device and receive them there. Thank you again for making time out of your day to listen to this broadcast, and we will have another one soon. Until then, please stay safe.